Well, sequencing of the genome will become a routine laboratory test, like you take X-ray of the chest, CAT scan, MRI, and so on. Obviously, the DNA is not the only story. It's the beginning. There are much more sophisticated things that we need to know. We need to know the RNA, we need to know the proteins, we need to know the changes in the proteins, we need to know the small molecule, the metabolome. But all those technologies are following by, because some of the principles are the same, so you apply them from one technology. At the end, we shall get a very good profile of the person, from the DNA to the RNA to the proteins, and we shall be able to get a good picture of the molecular landscape of the disease. Not only the current disease, but maybe also future diseases. And accordingly to design treatment and even preventive steps. So it's a big thing, big thing. Well, it's hard to say because I'm not in the economy of the pharma industry, but it will be even more costly because the pharma industry is investing a lot of money in every drug. You can imagine that one drug that makes it to the market, I'm not talking about, costs about now 3, 4, 5 billion US dollars. Now, most of the drugs don't make it to the market, so the companies are investing a lot of money. They are getting to phase 3 clinical trials, and then it doesn't go. So they lose a lot of money. On top of it, the pharma companies are facing a lot of legal suits. You know, there were many cases where a drug came to the market and the company had side effects of heart attack or something, and the companies were sued, and so on and so forth. So drugs cost a lot of money. Many drugs don't make it, but nevertheless money go into their development. And also some drugs are not living a long time, like antibiotics. They are not living a long time. On top of it, personalized medicine is coming, which is very dangerous for the companies. Because until now, let's say for cholesterol, you had one drug, statin. Okay, there are 2 statin, 3 statin. And statin helped some patients, helped partially some others, helped little, but you took it because there was no choice, even if it had little effect. Tomorrow, or in 5 years, there will be 5 drugs for statin. So the market will be the same, but statin will take only 20% of the market. Or there will be not 1 or 3 or 2 or 3 breast cancer, there will be 20 breast cancer. So there will be not 2 or 3 drugs for breast cancer, but there will be 20 for the same market. So the companies will have to go for new drugs that have smaller and smaller share of the market. So I suspect that the price is going to be even higher. Even higher. It's going, we are, in the economic side, we are not in good shape, I suspect. You will have to buy better and better insurance, private insurance, and even then, it may not cover. We'll have to see. But clearly, public insurance or national insurance, health insurance, forget about it as far as coverage intensively the health cost. And I'm not talking about the aging paid population with Alzheimer and Parkinson and so on and so forth. There is a way, but not significantly. Don't remember, because you mixed several things together. The initial discovery didn't discover the proteasome. You know, it was ubiquitination, then the proteasome came. So it was gradual, and then, you know, in the scientific community there is a big disbelief. People don't believe you. So they need that other people will come. You need to generate, you know, you start with little water, but you need to generate a river of belief that people will trust the... And then the proteasome didn't look initially as a good target, because we said that the ubiquitin system is so important that you inhibit it, you die. So nobody believed that you can inhibit the proteasome and nevertheless survive. So then it required many experiments, and then to find You know, even Valcade, bortezomib, was discovered by serendipity. And they screened proteasome inhibitors for numerous cell lines, and then they found that lymphocytes died. And lymphocytes are the cells that are implicated in the pathogenesis of multiple myeloma. So it takes time. I wouldn't say that it should take 30 years, but from an initial concept to a useful drug, it's about 15, 20. You know, the first papers came, for 7 years we were alone. Nobody believed us. We are the only people in the field.
And you expect it will be the same in the future?
The first paper, maybe it will be a little bit shorter,
Not
but there will be no miracles because we are human beings.
Yeah.
So let's say that somebody publishes something. Then there are also many technological issues. Think about microRNAs. There is still no drug with microRNA, though people are knowing about it for more than 20 years. So there is already a Nobel Prize on microRNAs, right? Went to Andrew Fire and Craig Mello. About almost 10 years ago they got a Nobel Prize. Nothing. So siRNA, still no drug. People are now talking about CRISPR. So it's a new technology. I don't know when it will be used in human beings. There are also many moral issues. So some drugs, there are some technological issues with microRNA. There are some belief of the community. There are some ethical issues. In CRISPR there is ethical issues. Can we correct genes? Will mother be able to choose the baby that she wants? Blonde, tall, intelligent, and then there will be, well, in Italy, you have the Vatican and the Catholicism. You know, the mother will say, no, I don't want a little boy with black hair. I want, so abortion, I mean, there are many issues that are coming up that slow the process, and I think that it's okay. Because we are all the time moving. So one drug comes that started 30 years ago, then another drug comes, so we are moving, we never stop. But I think that it's better for society to be slow, not awfully slow. We don't want to wait 100 years. And to think and to make sure that the drug is indeed working against the target and so on. It may slow, but I don't believe that significantly slow. Yeah, but we are making progress with cancer. Yeah. So think about the progress that we made in melanoma with the T cells modulation, when we are unleashing the immune system. This will get the Nobel Prize for sure. So even the clinical trials are taking a long time. Let's say that until now patients died from melanoma within 1 or 2 years. Now we cure part of them and the rest are living, many are living 5, 10 years. In order to know that they live 10 years, I need to do the experiment today and wait 5 years to see that they are surviving it. So even that alone is 5 years. And where is the development of the drug and the approval of the drug and the money for the drug and so on. So even the clinical trials take 5, 6, 7, 8 years. How do I know that the drug that I have is better than what I had before? I have to take 10,000 patients or 5 or whatever and to run a clinical trial and to follow one group, compare it to another group, to know that one is the better, because we want a better drug, so we always need a control group that will take the old treatment to compare it. So even the clinical trials take 5, 7, 8 good years. And that's after the fundamental discovery was done. So don't forget, at the end of the day, the experimental animal is not a rabbit and not a mouse. It's a human being.
So if we had to resume in one word the daunting difficulty of finding a general therapy for cancer, maybe that the word heterogeneity should be a good candidate, because in the beginning we understood that there is heterogeneity between patients, even with a similar clinical frame.
Right, you're absolutely right.
Genomics.
Which makes the disease much more complex.
Yes, and what is
not only that, not only that the disease is heterogenic, so there is no breast cancer anymore. There is breast cancer A and B and C.
Right.
But even within one tumor, there is heterogeneity in the cells.
Of course.
And they change all the time. There is genomic instability.
Yeah.
So you start a treatment and then the patient escapes because you kill one type of cells, but then other type of cells that are coming from cancer stem cells are emerging out and develop a new cancer.
Yeah, in fact. So
within the same patient.
Within the same patient. For instance, between the primary tumor
Exactly.
and metastasis.
Exactly.
So there is...
it's awfully complex. So therefore, people say that there will never be one drug for cancer. We'll always have to attack the patient with several drugs that coming from different directions.
There is, say, a desperate need for a common substrate to attack. I mean, for fighting the cancer.
Right.
Could be the ubiquitin system, such a common...
Yeah, but you see, even if you inhibit the proteasome, it's good only for multiple myeloma and for non-Hodgkin lymphoma, but it's not good for ovaries, for breast, for brain, for... So cancer is a name, but it's not a disease. There are 400 and more different disease cancers that are sitting under the umbrella of what people call cancer. But they are very different from one another. 400. And I believe that there are many more. Well,
personalized medicine.
it was an issue for us because we were in a technological institute and an engineering school. I think that it's improved now because many, not only in our institute, people understand that the life sciences will not be solved without engineering. Think about MRI. It's an engineering solution to a biological problem. Think about valves. Think about artificial organs. Everything. So I think that now we are talking more on interdisciplinarity. Beforehand, everybody was living in his own apartment. The biologists lived up floor, the engineers lived in the basement, everybody, and they didn't want to talk to one another. Now they realize that there is no choice. They need to live with one another because nobody can solve the solution without talking to the other, especially in medicine that became so complex. And we are heavily relying on engineering and technology. So I think that now it's better. It's not optimal yet, but it's better. Think about psychiatry and about autism. It's even worse, much worse. So yeah, you're right. We still, this is going to be a major problem, multigenic diseases and relative contribution of different genes to the pathogenesis. And first of all, we shall need to sequence a lot of people in order to understand it, to get all the linkage, all the network. At least to have the map. I'm not talking about treatment. And then maybe to identify one or two robust genes that are sitting on the crossroad. Hopefully there will be one. I'm not sure about it. So, there are still big discussions here. People say, okay, look at this hotel. Let's say that in one room there is a problem with the electricity. So instead of going to the room and starting to look at the detail, let's go outside to the main lines that bring electricity to the hotel and cut them. So why to deal with the details? And there is a big discussion whether we should go after a little gene or whether we should go after common mechanism like ubiquity, like apoptosis, like oncogene hunger. I mean, there is a whole school in biology, Weinberg and Hanahan, I don't want to go into it, you probably, that say, forget about the details. Let's go to the main supplies and cut it off. Because this is common to all, and that will kill the cell. And others say, no, there will be side effects and so on. I don't think that the discussion is settled. The discussion also has to do with financial issues too. Because going into the room and into the little outlet of the electricity costs a lot of money. Because you need to sequence tens of thousands of patients and classify and map, while if you go to the outside, you don't care. You cut the water. I go to instead of going to all the bifurcation, I cut the water. I cut electricity. So the discussion has not ended yet. And actually people say, look, we are 10 years into the human genome and we understand better, but no drugs came. And look how much money we spent on it. Look at the Broad Institute in Massachusetts, in Boston. You know, hundreds of millions of dollars, not a single drug. So the discussion is going on about the general philosophy, how to approach it, the disease. And we are not there yet. And yes, it's becoming more and more complex. But people say, let's solve the complexity by not going into it, but by shooting it from the outside. So instead of learning the detail, let's do something more robust. I cannot tell you where it's going to end, because it has philosophical issues, scientific issues, financial issues. It's very complex. And the discussions are still very stormy. Well, statistics is obviously a very important tool. But personalized medicine want to use statistics only in the background, because let's say that you have a breast cancer. A woman has a breast cancer. And she came to the doctor. And until now. And she asked the doctor, tell me what is my chances of getting out. And the doctor tells her 60%. Why? Because the breast tumor is like 5 centimeters and it metastasized to the armpit, but with surgery and chemotherapy, 60%. And then she asked the doctor, how do you know, doctor, that it's 60%? And he tells her, you know, I'm 75 years old. The doctor tells her. And I graduated medical school in Bologna about 50 years ago. And I have been an oncologist for the last 45 years, and I've seen 2,000 like you. And my statistics tells me, and not only my statistics, the literature tells me that patients like you have 65% of surviving or dying or whatever, doesn't matter, 100%, 90, doesn't matter, number. But then she tells him, doctor, you know, my name is, what's his Italian name? Roberta Modigliani. And I'm a person. I have a husband, I have children, I'm living in Via Romano 12, and I have a family. I'm a person. I'm not statistics. Tell me whether I will be out or in, because even 65, it's 65 yes and 35 no. Whether I should be a no or yes. And until now, he couldn't tell her. But in the future, he will be able to tell her according to the mutation. And there will be drugs to the mutation. Because if there is no drug now, he can tell her, okay, we have no drug for your specific mutation, but we can treat it generally by surgery and by this. And we still don't have a means to know whether one cell didn't go to your brain, because we don't have sensitive enough tools to tell whether one cell went to your bone or to your brain and so on. But a long time, chances will improve, and he will be able to narrow the story to a mutation. Say, yes, we can kill this mutation. We have a very efficient drug. So I think that we are getting, by sequencing and by knowing more and more about population, and by using statistics, we shall be able to narrow the range for the patient and to give them much better answers. And therefore it's personal. I think that the word, it's not only personal. President Obama called it precision medicine. So it's maybe the fifth P.
Yeah.
Well, I think that personalized and precision means the same, because we are precise at the personal level. We are not in a statistics anymore. We want to get out of statistics. We want to use statistics in order to generate the landscape. But at the patient level, we'll be much more precise. Maybe it's patient, maybe it's personalized, maybe, I don't know why the word P, the letter P is everywhere. Yeah. So it's precision, personalized, and patient. And that all means the same. That we are really aiming at a personal person, at an individual. And that's the idea. We are not at statistics anymore. We are at the personal level, which means a lot. we are developing much more precise tool to get out of statistics and into the individual. So I think that's the philosophical essence of what it is all about. But the road is bumpy. It's not, we are not there. We are moving, but from what all we discussed, the multi-genes. And as I said, breast cancer is okay, but think about autism, think about depression, think about these diseases that we hardly know anything about them. What do we know about psychiatry? Nothing. I was the student, and then I had my professor, and he had his own professor. So we are 10 and 10 years apart.